Hello everybody, welcome to Apollo Cancer Conclave. I am Dr. Vijay Agarwal, Professor and Lead Consultant, Medical Oncologist at Apollo Hospitals, Bangalore. So we are a team of 3 consultants and cover all Apollo sites at Bangalore to ensure that all our patients get the best treatment going forward. Thank you. I think going forward, ADCs are going to be the mainstay of treatment. ADCs are basically antibody drug conjugates, and what I mean by that is they are chemotherapy drugs that are tagged onto the antibodies. And antibodies have specific targets that they attack on, and because the chemotherapy is latched onto these antibodies, they are more precise and they go and attack on the cancer cells and are not freely available in the blood system. Hence, they reduce the side effects of chemotherapy, and you can give a significantly higher payload of the chemotherapy drugs to the cancer cells. So it's quite a novel, unique technique. It's very commonly used in breast cancer nowadays, and we have drugs like TDM1, TDXD, sacituzumab that we use in breast cancer, and these antibodies have really transformed our management of patients for both HER2 positive breast cancers and triple negative breast cancers. The other antibody drug conjugates that are coming up in a big way, particularly in treatments of ovarian cancers, in lung cancers, in bladder cancers, and I think we have to watch the space. There are over 400 clinical trials going on across the world with various types of antibody drug conjugates, and I think that is going to be the next phase. Over the next 5 to 10 years, we'll be seeing antibody drug conjugates being the mainstay of cancer treatment. So we've been using immunotherapy, particularly in Apollo, for the past decade or so, and I think immunotherapy has now become the mainstay of treatment for lots of cancers. And I could say that virtually all cancers, we use immunotherapy at some level, either post radical treatment or when the cancer is already spread in the metastatic situation. A lot of good data exists for well-established cancers or cancers that are very common, such as breast cancers, lung cancers, head and neck cancers, GI cancers. But in rarer cancers, it's very difficult to run a proper clinical trial with large number of patients. I think a lot of our experiences come from anecdotal experiences of using immunotherapy in rare cancers. Some of the rare cancers where immunotherapy has shown really good success are things like mesothelioma, which is a type of lung cancer, and Merkel cell carcinomas, which is a type of skin cancer. Of course, other cancers such as thymic carcinomas, and certain sarcomas such as alveolar soft part sarcomas or Kaposi sarcomas, immunotherapy has shown dramatic responses. Even in melanoma, which is a very rare form of skin cancer in India, not so rare in the Caucasian population, I think immunotherapy has now become the mainstay of treatment. So I think a lot of the immunotherapy, having been well studied in the well-established cancers, are now venturing into these rare cancers and showing remarkable results. And I think as with more and more experience sharing, particularly in conferences like these, Apollo Cancer Conclave, where we share our individual experiences, I think we will have more and more confidence in treating rarer cancers with immunotherapy. So immunotherapy does not work in everybody. There are certain cancers where we use immunotherapy without evaluating a biomarker, such as skin cancers or kidney cancers or liver cancers. But in the vast majority of the other cancers, we tend to look for certain biomarkers that suggest that immunotherapy is likely to work in those group of patients. And the 3 common biomarkers that we currently evaluate are what we call as microsatellite instability, tumor mutational burden, and PDL1, programmed ligand 1 expression. Now, these 3 markers can be easily tested in the lab using gene sequencing or immunohistochemistry testing, and the results usually take anything between a few days to a few weeks to kind of come through. Depending upon these results, we decide whether immunotherapy is likely to benefit a particular individual or not. I think microsatellite instability is probably the most important biomarker for immunotherapy effect. If someone has got microsatellite instability, I think immunotherapy does form the core part of the treatment. And the other 2 biomarkers, such as tumor mutational burden and PDL1 expression, does help us decide which patients are more likely to benefit from immunotherapy as opposed to which patients aren't. So immunotherapy are reasonably safe drugs. They don't have the similar kind of toxicity as other treatments such as chemotherapy might induce. I think most of the side effects that we see from immunotherapy are because of the prolonged use of immunotherapy, particularly because a lot of patients who do respond to immunotherapy tend to have a durable response, and they have immunotherapy treatment for much longer duration. In the first few months of starting immunotherapy, I think the common side effects are skin toxicity and some amount of fatigue. They're usually mild and not troublesome, but slightly more adverse toxicity in terms of damage to the lung, liver, or colon, or some of the endocrinopathies like hypothyroidism we tend to see after a few months of having started immunotherapy. Most of the side effects with immunotherapy tend to be mild, so grade 1, grade 2 side effects, where we don't really worry so much about it. Sometimes just interrupting immunotherapy for a few weeks and then getting back started on should suffice. However, occasionally we can get life-threatening toxicities, particularly with prolonged use of immunotherapy. And in those situations, we have to stop the immunotherapy drugs and put them on some immune suppression, such as steroids, for about 3 to 4 weeks. And once the immune system has kind of calmed down and settled down, we could take a call on whether we need to re-challenge with the immunotherapy or call it a day, so to speak. But yes, like I said, most of the patients don't really have any major problems with immunotherapy, but if they do, they established protocols and strategies to manage them. No, I mean, I think this is a fantastic initiative. I mean, I think we are currently the largest cancer care provider in India, the Apollo Cancer Centers, and having the Apollo Cancer Conclave, where all like-minded people, key opinion leaders come together to exchange ideas, to discuss trials and discuss real-world clinical problems, is a fantastic place both to attend and participate. And I think most of the oncologists, including myself, will go back with a newfound knowledge, a wealth of knowledge that will benefit and help our patients.